Can see the slide here and you can see what are his qualifications. I don't have to read out these qualifications except for saying that he has all the credentials to talk with authority on this particular topic. That is early intervention, early identification and intervention in neuromotor impairments. So I'm not going to repeat whatever is there on the slide, but I'm going to introduce him at a personal level. I'm going to talk about what I know about him as a person. Dr. Asis Kumar Ghosh is an extremely knowledgeable person, and his knowledge comes from not just reading from books, but it comes from actually immersing himself in this field for more than 2 decades. And he has worked exclusively in early intervention area. So he probably knows more about early intervention and early identification than anyone else I know. So I'm really looking forward to what he has to tell us. I'm eagerly waiting to learn from him. He's an extremely humble person. He talks very less, but when he talks a lot of sense. Dr. Asis Kumar Ghosh, the IACP is privileged to have you here as a speaker. Welcome.
Thank you. Good afternoon, all of you, and welcome to this particular webinar. This webinar is on early identification and intervention. I have kept it like that because, I always believe that if there is early identification, there has to be early intervention, and the management has to be implemented through the families. So these two components are actually inextricable. You cannot separate them. That's why what I did is I have kept these two subjects one after another. First, we will talk about early identification, and then we will talk about early intervention. And mostly, I will be talking on screening and surveillance during this identification process. Once the identification is done, and then how the family or the child has to be taken into the early referral system, into the early management of cerebral palsy or neuromotor impairment. So, so I will start with my first slide. So this is early identification and intervention. And then we will start with early diagnosis of cerebral palsy. In infants, clinical signs and symptoms of cerebral palsy emerge and evolve over the 2 years of age. So, it's a gradually evolving process. And as the cerebral cortex matures, the picture becomes much more clearer to us. But in order to identify very subtle signs, and if we can correlate that with the birth history or medical history, then we can definitely find out certain subtle signs which, if can be treated earlier, can be intervened earlier, the chances of better improvement we can see. So a combination of standardized tools should be used to predict risk in conjunction with clinical history. So a medical history and neuroimaging and standardized neurological and standardized motor assessments Now, all these components, if they show a congruent findings, which is indicative of developing cerebral palsy in future, then we should immediately start intervention. That leads to prompt referral diagnostic specific early intervention. Why have I written diagnostic specific early intervention? Because if there is a hemiparesis, you do with um, constant induced movement therapy. If it is a diplegia or quadriplegia, you start with the whole body and then treat it. In any case, cerebral palsy is a whole body problem, so we'll have to treat the child as a whole, and we'll have to take the parents into confidence, into our fold, to explain and how to carry over the treatment at home. So now you are in a model setup. You are in a tertiary care hospital where the facilities are available, trained manpower is available. So there are two very commonly used tools. One is general movement assessment, which was done, the work has been done by Dr. Prechtel in Austria. And then many institutions, each institution use their own protocol. Some institution use Alberta Infant Motor Scale and then Hein at 1 year of age. Some institution use BSID, Bailey Scale, Bailey 3. Some institution use the DASI, Developmental Assessment for Indian Infants, and others. So I will start with general movement assessments. I'm sure you all know this, but this is just, I'm sharing my thoughts, and I have learned many new things recently. So I have included in my protocol as well. So general movements, these are spontaneous movements. Cortical maturity is not there. So from where these spontaneous movements come, it is called central pattern generator, CPG, in the brain stem and spinal cord. It emerges at 9 weeks of post-menstrual age. And GMs, it's a gestalt perception. You will have to see the whole child, the movement of the whole body, and it involves the entire body. So GMs vary in sequence, speed, amplitude, intensity in infants, both preterm and term. And variations of GMs are strong indicators of typical development. From high amplitude to low amplitude, high speed to moderate speed, minimum speed, these variations as the child grows come towards term age, is the strong indicator of typical development. If it is not there, we will come to that, we will see that. So preterm GMs are mostly of larger amplitude, faster speed, sometimes jerky. GMs at term age at 40 weeks, it's moderate speed, smaller amplitude, and writhing. So assessment can be done by watching video recordings of infants of duration 1 minute to 2.5 minutes. You can also observe the child directly. So there shouldn't be any external stimuli. Nobody should stimulate the child, well, look this side, or, ring a bell or something like that. No visual stimulation. And 2 or 3 videos, and then around at term age, and one at term age 38 to 48 weeks, and at least one recording between 9 weeks to 15 weeks post-term. Because by 9 weeks, we will see how the fidgety movement comes, and if there is an absence of fidgety movements by around 9 weeks or 3 months of age, then there is a strong possibility of child will have something else, maybe cerebral palsy, autism spectrum disorder, whatever it may be. It has got very high sensitivity, 98%, specificity 91%. It is cost effective, but it requires training. So these are the categories of GMs at preterm and term age. The normal repertoire of movements, what we call, is there will be a movement sequence, It will start from one limb, flow over to the other, involves the trunk, go to one leg, and then moves close to the another leg. So movement sequence, amplitude, speed, and intensity are variable. If it is poor repertoire, then we will see there's an incomplete sequence of movement. Suppose you start, the child moves the right arm and then suddenly stops. Or in the middle of the movement, before completing the movement, the child stops that movement. So it lacks in variability, uh, amplitude, speed, and intensity. So I will show you a video. $40
Sir, you have to share the screen to show the video.
Okay, sir. Okay.
ऐसा 1 इंच की पट्टी आन दे दो क्या माया ज्यादा नहीं हाँ वो ऐसा वो छोटा पूरे को ये दिख रहा ना इतनी आन दो
Can you see the video now?
Yes.
Okay, thank you.
Yes.
I will start the video from the beginning.
Hello.
You can see a lot of variability, but as the child has come to term age, 40 weeks, the speed is moderate, amplitude is less, but you can see the lot of variability, the movements, quality of movements, opening of hands, movements of feet. And this involves the trunk as treatment. We will talk about the treatment. How do we involve the whole child in the treatment? We don't treat the limbs of the child, but we treat the whole child. So, yeah. So there is now there are further categories of atypical GMs. A very important is cramped synchronized movements. There is lack of variability, there is stiffness, trunk and limbs contract simultaneously and thereafter relaxes simultaneously. So it predicts spastic cerebral palsy, unilateral or bilateral, with 98% specificity. And this is around the age of 34, 35, 36 weeks. And prolonged CS leads to GMFC level 3 to 5, and shorter CS leads to GMFC level 1 and 2. So I will show a video of cramp synchronized movement. So there is a contraction, the child becomes stiff, and
Sir,
then
share video. Share video.
okay. Sorry, because
आवाज क्यों बंद हो गई?
The child becomes stiff and then relax. Again, child gets stiff and then relax. Child gets stiff and then again relax. So the further categories would be chaotic, which is abrupt, large amplitude with fast speed, jerky, tremulous. And what is the outcome of poor repetitive movements? Outcome of poor repetitive GM is dyskinetic cerebral palsy, IEM, inborn error of metabolism, autism spectrum disorder, or it could have absolutely normal motor outcome. Now, this is very important. fidgety movements, it appears around 9 weeks post-term by around 3 months of age. And it involves the entire body. And there are lots of midline movements. There's a small amplitude of movements involving head and neck. And it is of moderate speed. So fidgety movements is variable acceleration. It's continuous. It continuously happens and it's state dependent, but it is not circular. It slowly disappears around 5 months when when intentional movements become dominant, and the cortical maturities start taking place. And fidgety movements and intentional movements can co-occur. I will show you a video of fidgety movement. Now let us see what is happening. You can see here the continuous movement happening, very small amplitude. It involves the head and neck, and you can see the hip movements, feet movements, and it is multi-directional. It moves to different directions. It's not stiff like cramp synchronized movement. You can see the small movements of the hands and fingers and wrists.
वही गाड़ी रुक के निकल जाऊंगा वो लोग सोचे उन्हें जब भी जरा और ज्यादा नहीं पड़ा जिब्बल को चलते थे जरा रोक को लिया हाँ वही ग्लास में नहीं देखा नहीं देखा फोन की घूम में इधर नहीं करना पेपर निकाला हमें पढ़ना ही निकालता इसका नाम बताओ
Yeah. So any deviation from fidgety movements, which is absence of fidgety movements between 3 to 4 months, is pathological, a strong indicator of cerebral palsy. Fidgety movements less than 3 seconds may be sporadic, which again may have normal outcome or may have uh, uh, again the child becomes cerebral palsy. Too large amplitude of fidgety movement is again abnormal. Now I have come to another very regularly commonly used scale, which is known as a Hammersmith Infant Neurological Examination. The objective of Hein is it's a very simple, quantifiable, validated neurological examination tool for infants. It is used for optimal scores and prediction of gross motor outcome in preterm and term children between 2 and 24 months. Can be completed in 5 to 10 minutes, so it will not take that much of time in your busy OPD. And it has got 90% sensitivity. I will not go through the pro forma of Hein. What I will do, I have taken out the main points which the Hein is talking about, and I will explain that, how abnormal tone can affect your posture, how your posture can affect your tone, and which are the components of this Hein. So it is a, you need a scoring pro forma, a small red ball or a red ring, a rattle for auditory testing. You need a tendon hammer and toys. So under Hein, there are neurological items, and the first is its cranial nerve functions. Under cranial nerve functions, what we should see is facial appearance, smiles, or closing of eyes, facial grimaces, and you have to have a very vigilant eye on the child to observe all this. We should look at the eye appearance, means whether both the eyeballs, whether there is any squint, both eyeballs are moving. There is auditory response on the left side or auditory response on the right side. And you should see the visual response, sucking and swallowing. Now, under posture, you have to look at the child's sitting posture, and under sitting posture, you look at child's head and trunk. And all these stick diagrams are there in the pro forma. So you can just put a circle what you are seeing with that child. So it's arms at rest and then hands, legs in a long sitting position, legs in supine and standing. So why they have said that, you need to look at the child's legs, what is happening, what is the pattern in long sitting position, because you see the position of the hips, whether they are internally rotated, externally rotated, what it is. And internal rotation, again, it might give you some indication of adductor spasticity. So, and that under quantity of movements, whether it's normal movements, equal on both sides, whether it's excessive or sluggish, and whether it's minimal or none. So under quality of movements, it's free and alternating smooth. I think, you can make a correlation now with fidgety movements, which is again free, alternating and smooth. Jerky, slightly tremor, cramp synchronized, you see in spastic cerebral palsy, extensive spasms, athetosis, athetoids, ataxic, very tremulous, myoclonic spasm, and dystonic movements. So under dyskinesia, it's actually this athetosis and dystonia comes. And under tone, what should we see? We need to see the scarf sign. By doing the scarf sign, we need to make out whether there is any stiffness around the shoulder. By doing a passive shoulder elevation, you need to find out the stiffness of the muscles, pronation and supination of forearm. You will have to do this passively. Adductors of hip, popliteal angle, dorsiflexion, pull to sit, and ventral suspension. So under pull to sit, you actually see the child's head control in supine position and whether the child can anchor at the pelvis. Under ventral suspension, you see how much the child is lifting his head. So all these, postures and testing postures give you some idea about the tone in that early age. So under reflexes and reactions, you need to see tendon reflexes, arm protection. You pull the child will bear weight through one arm and get up. And vertical suspension, you look at the free movements, flexion and extension of the legs. Under lateral tilt, you see the child's head writing ability. And forward parachute is actually protection of arms, protection through arms. So milestones, and these milestones are actually not scored. High scoring is done in such a way, if you do not see, you put 0. If you see, something is happening, so it's 1 and then 2. And between 1 and 2, there is 1.5. You can put 1.5 if you are not happy with that particular movement or posture. And if you see the child is in right posture at right age, then you can give score 3. So these are the posture where you will see milestones, where you will see those are not scored. So high milestones looks at the child's head control, sitting, voluntary grasp, kicking in supine, rolling, crawling, standing, and walking. So high also looks at the behavior of the child. So under behavior, you look at the child's state of consciousness, whether the child is unrousable, drowsy, sleepy, but wakes easily. So you need to make out and come to a judgment that what it is. And if the child loses interest and maintains interest, so it's the behavior, state of consciousness. There is emotional state, whether the child is irritable, not consolable, irritable, caregiver can console, irritable when approached, neither happy nor unhappy, happy and smiling. So when you will actually observe the child, you need to put a tick or put a circle there, what you are observing. And under social orientation, you say avoiding, withdrawn, hesitant approach, accept approach, and the child is friendly. So cranial nerves, if you take the maximum score per item is 3. So under cranial nerve, there are 5 items. So the maximum score can be 15. Under posture, there are 6. So 3 into 6. The maximum scoring can be 18. The movements, 2. So whether it's the quality of movement and quantity of movement. So you can give maximum score of 6. Tone maximum score of 24. That means there are 8 items. Reflexes and reactions, you have got 5 items. So now what they have done a cutoff score by which you can make out. So here I have found out from Hataja and et al.'s work in 1999, the scores below 57 at 3 months are 96% predictive of cerebral palsy. So you can now see that if you do GMA and then Hein, or if you do any other objective assessments of which combines all this, tone, consciousness, posture, milestones, and then you need to come to a conclusion looking at the score and refer the child for early intervention, which is most important. Now you are not in an ideal setup. Suppose you are not in an area, you do not have trained manpower, you are in a village and you are looking at the child, you are seeing a child who is 3 months old. What do you think? You cannot assess a child? Of course you can assess a child. So you apply your basic knowledge on child's tone, posture. See what is happening in each posture. So generally what we do when there is no tools available, if you find a child is unable to sit independently by age 9 months, it's a doubt. You need to do a thorough assessment. if there is asymmetry in hand function or the body as a whole, one half is, doing more than the other. So, you will have to assess. And unable to bear weight through the feet flat. You make the child stand on his toes. So don't wait for a day or for a minute. Assess the child, explain the child's problem to the family, show some activities which all these problems can be reduced at an early age. So, you need to do a holistic assessment, because when you look at a child, you look at the child's vision, you look at child's hearing abilities, child's communication abilities, and then the motor abilities, the child's tone, postural asymmetry, quality of movement, and function in each position. In supine, what the child can do, in prone, what the child can do, in sitting posture, what the child can do, in standing, what the child can do. So you can do, and you can just write it down in a piece of paper and come to a conclusion that there is some problem. Now the most important part of it is intervention. Intervention. Let me start with certain very basic things which we often overlook or tend to forget during our interaction with the families, like greeting the parents, greeting the caregivers. As soon as they come to you, you need to greet the child as well. You need to introduce yourself, who you are and what is your role, what you are going to do. Explain your role to the parents and caregivers in a very simple language without using medical jargons. Now, while interacting with the parents, keep a vigilant eye on the child's movements, on child's interactive abilities with the mother, how the mother is carrying the child, everything you need to see. And while you are talking to the parents, you are actually observing and assessing the child. Observe parent-child interaction, child's visual skills, and you can make out. You do not have to do separately one by one. Hearing response, communication skills, and seizures, if any. Sometimes, you will see subtle myoclonic jerks, which the parents think, is because of the sound outside that stimulates the child. So child, gets startled, but actually it is not. So you need to report to the pediatrician or the pediatric neurologist, whoever is there in your hospital or in your setup, that during your assessment you have find all these subtle jerks which may need further investigation. So remember 5 A's, like ask questions to understand what the current situation is, what the child is doing at the moment, how the mother or the family is handling, how they're coping with the child. And you gauge parents' understanding. How much do they understand about their child? What do they think? Most parents, when they come to us, they say, my child is not sitting, my child is not standing, my child is not walking, my child is not talking. See, to the parents, these are the major milestones. They are not bothered about fine motor skills, this and that, lifting head in prone, all these things. So you need to gauge the parents' understanding, rectify inappropriate activities. Sometimes, the way of carrying is not proper. So in a very gentle way, just coach them that this is how you can hold your child. And if you hold your child in your lap in this way, you can probably look at the child's face and child eyes, eyeball to eyeball, and talk to your child. So your intervention starts there. So I'm just repeating my slide, like how he or she is carried. What about the mealtime activities? Most of the children who do not have head control will not develop chewing ability, swallowing ability. So they are mostly fed liquid in lying position on mother's lap. And what about the play and leisure activities? What they are doing? So position for toileting, bathing, grooming, any other activities. If they are having therapy previously shown by any other therapists or from any other hospitals, what about the outings? Is the child taken out of the home? What are the child's hobbies? And here the note is, what he or she does, what the child does, where the child does, who facilitates all these activities, in what position does this child do these activities, or any other relevant information that you gather. So reflect on information gathered and give feedback. Appreciate efforts of parents, and this communicates empathy because parents come to you for help. Now if you start sometimes start shouting at them that you are not doing the therapy what I have seen, and that's why your child is not improving, this is not the beginning of your intervention. So do not be so directive or condescending for the parents, and you affirm the appropriate activities. Say well done, so well, and then you add one or two new ideas what they are already doing. Check how they feel about these ideas. So you give them one or two new ideas what they should practice at home. Answer problems of challenges they are currently experiencing. Together come up with possible solutions to those challenges. So you ask the parents that what do you think, how you can manage this, and from their lead you take their lead and you try to modify the activities what they are doing at home. Please remember, in the 45 minutes of time in your hospital or in your chamber, the child will not improve because neuroplasticity is something the brain needs to be bombarded throughout the day, and it is only possible if you can incorporate all these correct posture and right movements in daily care activities, and then you can expect some changes in the child because there will be lots of repetitions, and child motivation is related with the development of the child, and you take an action. So after all your assessment, you have to keep a goal in front of you. Goal is actually what you are going to achieve in say 15 days or 1 month of time or 3 months of time. So record the child's abilities. If the parents come from a very far away area, tell them that whenever is convenient. Can they come after 3 months? Can they come after 4 months? Can they come after 2 months? So according to their convenience, you give them an appointment. So you write down those activities which has to be incorporated in the daily care activity. Because for our parents, physiotherapy, occupational therapy means a list of exercises, which is actually so record the child's abilities, write goals of intervention in consultation with the caregiver. See what is doable and feasible for the parents to do at home. The intention of goal achievement is that children should improve functionality. So it has to be specific, measurable, SMART goals, you all know. So it has to be achievable within a specified time period. And this time period depends on the parents' availability, when they will be able to come to see you again. The strategies are actually written in their exercise books. So write the strategies that could be incorporated in child's daily routine. These are suggested activities for caregiver, parents, or health professionals that support goal achievement. So caregivers coach the caregivers rather than giving them directives. So how to achieve the goal that has been set during the assessment. And you have taken them into your confidence and say, well, if you do this, let us see how your child improves. When you come next time, we will see. So incorporate intervention in caregiving activities. I am emphasizing on this because I have learned this in my long experience that whatever good physiotherapist, occupational therapist, speech pathologist, psychologist, special educator you are, until and unless the parents understand what you are trying to say and what is doable for them at home, it is no point, giving them lots of advice. So coach parents rather than advising them or giving them directives, explain how the child's overall development can be facilitated through play and caregiving practices. I will be showing some videos on how all this can be incorporated in a particular context-based activity. And physiotherapy, occupational therapy is not a list of exercises for a child. So demonstration for parents, the caregivers, like how to integrate all domains of child development in one intervention. When you look at your own child, suppose 3 months or 6 months or 1 year of age, do you really separate the motor, the vision, the hearing? No. You look at the whole child. It's like reading a newspaper. You are not reading alphabets. You are seeing, it's a kind of gestalt. You are seeing the newspaper as a whole and you can read. So, think of activities which the parents are doing every day at home. Every day at home. So incorporate your therapy in those daily activities. See how it will be done. I will be showing you. So how to integrate all domains of development in one intervention session rather than compartmentalized one. So why I am saying this? Because we often say that आपका बच्चा का एक्सरसाइज हो गया तो ठीक है आप वहाँ जो स्पीच रूम है वहाँ पे चले जाइए and then occupational therapy hai wahan chale jaiye. So what is happening, at the end of the day when the parents are leaving that hospital, if you ask that parents how much did you understand about your child's problem or what you were supposed to do, they are really confused. So being a therapist, physiotherapist, what I do, I go to my colleagues or when I sit on the mat with my other colleagues like special educators and social workers, I just ask them, what you are thinking, what is the child's cognitive abilities are, and what sort of planning you are giving, what should the child learn, and I take the ideas and I write it down in the right posture. The child will hold the glass and will drink. So it's a kind of you combine all these activities in one session. So parents have to do not have to spend extra time for that. In any case, the mother has to bathe the child, the mother has to feed the child, mother has to do the dressing and dressing, toileting with the child. Every day the mother is doing or the father is doing. So you incorporate those activities. So your therapy will be done 24 hours a day. And that's how brain plasticity can be developed. So it is one child and one parent and 5 professionals are advising and 5 different languages. So why can't we give a comprehensive program where everything is incorporated and it would be much easier for the mother or the parents, and you explain them that when you make your child sit, actually you are doing therapy. The child is keeping his head upright, the child is looking around, and then when you are showing a nice toy in front of the child is actually using his visual skills. So it's motor, it's vision, it's hearing, everything is coming, and ultimately all these sensory streams, the confluence is at the sea. What is that sea or samundar? It is the cognition. All our senses, they conglomerate and develop our cognition. So in our therapy, if we can follow that, I think it would be better. I mean, this is my experience, this is my learning, whatever you want to say. So this is an example. Integrated, I call this as integrated intervention. You see that there is this is just an umbrella, and you with the string you hang some nice balloons and different kinds of, and very cheap toys. You do not have to buy expensive toys. So it's a complex integration of motor, vision, and cognitive skill. When we talk about vision therapy, because quite a lot of our children also have cortical visual impairment. Multiple areas of that brain is damaged, which helps our vision. So we do not call this as visual stimulation. We call this rather vision stimulation because it's the complex integration of multimodality, your sensory system, motor system, and which helps to develop the cognition. So mother physically assists the child. Here you can see the mother is holding the child's hand because the child is quite stiff. And we have given a cushion to reduce the distance between the mother's face and the child's face. And then the mother is holding the child's hand and help the child to pat that balloon. So treat the child as an entity, not his limbs, not his head, not his neck, not his arms separately, not his fingers separately. So consider feasibility of time and energy constraints of parents. You will have to think about that. Nowadays, both parents are working and the working atmosphere is different. A mother who is working in the paddy field comes back home totally fatigued, drained out. You cannot expect that mother to do therapy for half an hour, do speech therapy for half an hour, do special education for half an hour. So you will have to really think about all this problem. Ensure that suggested activity has components of motor skills, communication, cognition. Implement those in play and activities of daily living, which I have been telling you time and again, such as bathing or meal time. So I will show a video now.
Hello. Ashish, you'll have to share the screen.
Yeah, let me open. Yeah. Stop there. Let us see. This child is spastic quadriplegic, has microcephaly, having myoclonic jerks. And what is actually happening here? You can see the position of the child. The child is in side lying position. Child also has got some visual problem which you could make out. Now she is my colleague. At the back is the mother who is observing what is happening. So, this crunchy paper, and we are just switching on and off the torch. And I am helping the child to touch. My objective is to the child must look at it, feel it. So it's a kind of vision stimulation, motor, and the child is going into, from sideline to half prone and again coming back. So you can see this, and please give your feedback at the end because I need your feedback. What do you think about all this? So I just increase the volume and find that, so what I am saying, Nasif, can you touch it? and see the crackling sound. And it's switched off. We are waiting for his response. She is asking again. So this is communication. You see the language and communication. We are waiting for the child's response. She is asking again. In Bengali, we say abar means again. Again you want to see. Again you want to touch. So, it's a kind of turn taking. The child is waiting and coming back to touch it. See the child, you can see the child's eyeball movements. I am helping him to reach out and to do things, pulling and hearing that crackling sound. See the child's consciousness level has really gone up. Child is really attending to this activity. Sorry, it's taking time. The next slide is not coming. So you choose the activity or the toy. Use toys available at home. You do not have to buy expensive toys. You can make some toys. Give the parents some ideas that how it can be made at home. Enrich immediate environment. You see, by the word enrich, I want to mean, not it's the ambience of the room. You do not have to change it. But what you need to do, you need to consider the people who are there and the materials, like what toys you are using. Maybe the curtains you are using, maybe it can be more colorful, or black and white stripes for the children with cortical visual impairment. You can have colorful plates during mealtime. Involve people. I always tell the fathers that whenever you come back from your office or from your work, you just say hello to your child. That is neuroplasticity. That is your involvement. So how many times involve the grandparents, involve the siblings in this, and this has to be again activity based. I will show you the next video. What is happening? Just a minute, please bear with me. Yeah, you see this, she is the mother. This is a 3-month-old child.
Share kariye.
This child, this child had severe birth asphyxia, HI stage 3.
Share the video, please.
It's okay. Sorry. She is the mother, 3-month-old child, HI stage 3. We are telling the mother that please smile, talk to the child. And see, there is some inhibition in the mother. Probably either she is very shocked looking at the child's condition. You will have to think of all this, consider all this. And then we called our therapist. I will stop here. And then, and you see what is happening. See the difference. She is our therapist. See how she is talking to the child. The child is probably tired, but still, I have kept this video to show you the difference. Although the mother is a very known person, child knows the mother very well, but as because the mother is not talking to the child, child's response is less. See, the child is looking at our therapist's face. See, the child is feeling something. Have you noticed that? So, parents need to talk a lot. So, sorry. So engagement in reaching out, in standing, no, it has come. Okay. Mother-child interaction I have shown, and I will show you the next mother-child interaction in a minute. Now look at this mother. Look at the way she is holding her child. This is the same child, you saw his video. See how the child is reacting to mother's voice. See, this is communication. The way the mother is holding, this is part of your therapy. The child is holding his head in the middle, in upright. Child is expressing, so it's fun for the child. So all your ICF codes are satisfied here. Yes, simple activities, and if you can explain this to the mother, that how it helps the child's overall development. And see what is going to happen within a few seconds. Look at him. See, look at him. He is trying to touch the mother. And then and there, and this is known as interaction. Actually, this is known as responsive caregiving. Immediately it responds. The mother responds to the child. So let us see another video where I have kept, there is engagement and reaching out in standing. These are some bangles. And out there is our special educator. She's working with the child. I have just told the mother that you hold the child in a standing position. So child isn't standing, she is shifting her body weight from right to left, and we are also moving the toy from right side to left side. Child is using is changing his gauge from right to left, trying to understand the language, what she's saying. And she's saying that, use your both hands. Here, this is another example of integrated intervention. This is just a simple wooden bar, and we have wrapped the LED. And in a dark room, the mother is working. We have also hung some streamers. So those are really glistening and attractive for the child. So look, the child is looking at the lights. Child is engaged in that activity. Mother is smiling, giving her feedback to the child. All these things, this is a kind of, that is why this is integrated. Everything is taken into account. So you break tasks into smaller steps. Goals must be appropriate to individual ability, and you celebrate every success of the child. So what are the principles of learning? If we look at the principles of learning, we can see that learning is a new skill and it is an active process. So no passive movement, passive stretching of limbs can actually help the brain to grow, brain to learn. Carryover of intervention through the day in ADL, activities of daily living, and thereby you are repeating the same activities through the day. Variability helps learning skills. So you apply novelty, apply your ideas, new ideas. Child's active participation is essential for learning. It has to be meaningful, context-based, and goal-directed. So what is happening here? The child is actually holding the bar. All the toys are kept on the bed. Child is standing. Child is trying to taking steps sideways. So your motor goals are fulfilled. Your vision is fulfilled. Child is holding. So fine motor, everything is being satisfied. Here you see, look at the child's face. The child is so happy. And it's a very simple thing to, you can also, the parents can also make it at home. And look at the mother and the child. The mother is sitting behind, helping the child, holding the child, giving some stability, and let the child play. So I have tried to put it in a schematic way, like, while bathing, you can actually teach, helping the child to learn movement of limbs, to learn body parts, recognition of objects like soap, mug, bucket, whatever it may be, towel, and you are learning, your child is learning language. Look at this. We have just float some balls on the in the bathtub, and trying to get the child's attention there. It's a very young child, 4 months old, holding the child and helping the child to look at the ball. And we are stabilizing the child's trunk so that the child can use his head. So during mealtime, the child can get the flavor, the aroma of food, the color of food, the names of the utensils, names of the food. This is how you can make every situation is a learning situation. And now, what do you think, when I supervise in my center the children's mealtime activities during 1 to 1:30, I often feel the food are generally, tasteless, they look whitish, they look brown, nothing can attract the child, and especially children who have got cortical visual impairment. So I have told one mother that, can you think of, so I have given her the recipe, like, what are the things you can use. You can see here the green ones are spinach, pureed spinach, grounded in a grinder, and then there is beetroot boiled and put here, and the white portion is the rice. So we are putting everything, and the yellow portion is the egg yolk. So this child has got a problem in swallowing and chewing. So we have made the food puree and also make it more attractive to the child. So our objective is we need to now shift from impairment to function. So transition from impairment based approach to that of function and participation based approach. Activities should replace exercises. So exercises, actually, we colloquially use this, but we need to change ourselves. Our pediatricians need to change themselves. That how you can explain the parents that have you done these activities? Have you played with your child? Have you played with your child in this way? Have your child ever stretched his arm forward in order to touch you? So it's more of activities rather than exercises. There is no list of exercises. It's mostly activities. It shouldn't be therapist centered rather than it has to be child centric. So this is probably the last video. So I will show you, because videos speak louder than your words. No, it's the last one. So I am actually helping the child to get into standing position. This child actually doesn't have spasticity. Mostly probably have some syndromic problem, and it's cognition. So it's lots of talking is required. And you see the mother is observing. Mother is looking at us, and she has held the mirror. Child is looking at. So child is probably looking at his image on the mirror. So it's getting into standing. So your motor activities are being done, and then the child is reaching, looking at his own image in the mirror, touching it. So it's a kind of whole activity that you are doing. She had given her a few crayons. Child is not actually concentrating. She is saying that let us do some crayoning, make some marks on the paper, and she is showing. And now see, she is imitating. So now you get my point why I have kept all these videos, because I want to show you how a therapy session has to be very productive. It is productive for the parents, and the parents feel that really something has been done with my child, and they can also repeat those same activity at home. So I have kept some goal setting cues. So under mobility, you can write And these are some examples, like Robin will roll over onto his side from a supine position to reach for a toy held by the parent. You see here the participation comes in. Father is saying that, come on, get this toy, hold this toy. So it's a kind of constant interaction, and the child is learning to roll over. So motor activity and communication and participation and fun, everything is taken into account in play. The Robin will reach out with both arms for a toy held by his parents. Again, the parents in a supported sitting position. Mealtime activities. Robin will swallow pureed food given by the feeder with chin support. So I will end here. Before that, I will express my sincere thanks to those parents who have happily allowed me to take the video and pictures of their children for this webinar. Ma tujhe salam. Now I have shared my information, my experience. Look forward to your feedback. Thank you.
Thank you so much, Dr. Asis Ghosh.
Okay, thank you. Thank you.
One of the most practical lecture that I have heard, thanks to your videos. A lot of things were explained. And if I can quickly summarize what you talked about, was your topic was early identification as well as intervention.
Yes.
In neuromotor impairments, you highlighted how assessments can be done even in the absence of standardized tools. This is a very important message for many practitioners who neither have the time nor the tools to do the assessment. Then you also talked about you gave a very important message about how before we plan assessment and interventions, how we should ask about what is the typical daily life of a child is like, and what are the daily activities that are performed by the family with the child, and then incorporate your therapeutic interventions within those daily activities.
Yes.
You also repeatedly emphasize that therapy is not just a list of exercises.
Absolutely.
And I think an important message is combine physiotherapy, occupational therapy, vision, hearing, cognitive, all interventions in one game, one activity, which is so important to understand and for health professionals to remember. And very strong messages replace the word exercise with activity. So I think if people can take away these messages from your lecture, a lot of good would be done following your lecture. I think we have time for about 3 to 4 questions. Very quickly, if you can address them.
Yes, yes.
So, yeah, we have a question from Mr. Pranab Kumar Satpathy, who is asking, is W sitting correct, or should we try to intervene to prevent W sitting?
Okay. There are a lot of children with normal tone and intact neurological status. They also sit in W sitting position. There is nothing wrong in it, because they can change immediately. They can get into kneeling position. They can come out of it. They can get into standing position. So this is just one posture for that child. Children mostly with spastic diplegia, they prefer to sit in this position because they can emancipate their hands. They can free their hands for play activities. So in long sitting, actually they are very unstable. So they want to play. So what I suggest to the parents that, you can allow him to play for half an hour in a day, or what you can do, you can give some alternative postures, like, sitting in an asteroid position on a low stool, sitting in an asteroid position on a bench with legs apart, with a table in front. So you just change the posture of the child's play. Don't stop the child's play. If you cannot stop the child's play, but let the child play, but in a right posture. Because this children with spasticity, if they sit in W sitting position, they cannot come out of it, and later on that will increase adductor spasticity, tight tendo-Achilles and all that, probably will require surgery in future. So from the very beginning, if you can tell the parents, I always suggest a tricycle for mobility, because they start bunny hopping using this W position. So you need to give alternative, think of alternative positions and think of the home situation, what they have, what they can afford.
All right. The second question, quick question from Gurpreet Kaur is, what should we look for? You said that observe the child during toilet activity while the child is sitting on the toilet. So what should we look for in position? And what is right position and what is wrong position?
Number one, we generally suggest some kind of toilet seats. So it has to be very stable, and the child has to be sitting the way we sit in a chair. There is a cutout hole in the middle. So, and there is a bar in front so that the child doesn't fall forward from the chair. And that chair can be placed directly to the Indian style toilet or on a Western style toilet. And the child's feet should be on the ground. And if you want to, if it is a mobile child, I would suggest, if the parents can afford, of course, that fix some strong bars, aluminum bars from the door to the nearer wall of the commode or the Indian style seat, so that the child can actually side walk and can sit and can hold on to something and perform.
Okay.
And regarding washing and all that, nowadays the bottom washers are available. You can use that. I mean, you decide, because toileting is really, you have to make the child independent as early as possible. And there is an issue of privacy as well. So you guide the parents, but as far as the seating is concerned, there has to be a proper seat on the toilet.
Okay. One quick question from Dr. Dhruv Mehta. At what age can you reliably declare to the parents that the child has cerebral palsy without having tools with you? I mean, you don't have GM or Hein. So what is the safe age at which you can declare this condition?
Dhruv, from my experience, I am telling you, I do not have to wait till 9 months. That's the sitting age. I see very small babies, very young babies, and I keep on watching their movements. And if I find any discrepancy in movement, and sometimes if there is no abnormal tonicity in the child's body, sometimes it is a delayed cognition, delayed understanding that also delays the motor development. So it is a combined decision. I never ever use the word cerebral palsy, even if I am 100% sure that the child is going to develop cerebral palsy. I explain the parents that at this age the children, they do this. So why can't you, can you facilitate all these activities? And I demonstrate them. And gradually, you see, in any case, they will get the diagnosis from the pediatricians, from the neurologists, because they will be visiting many doctors while seeing you. So, it's a kind of, without telling the parents the word cerebral palsy, because it's quite dangerous, because I have seen the diagnosis cerebral palsy has turned out to be something else later on. The child was deteriorating. Initially, we thought that the child is having cerebral palsy, but later on, it turned out to be leukodystrophy, and so there was a deterioration. So you treat the child as you see. I mean, if there is a discrepancy, if there is no midline oriented movements, tell the mother, hold the child and work on it. I mean, there is no, I don't think there is any need to tell the parents, beforehand that your child is going to develop cerebral palsy.
So as you rightly said, there's no need to label, just correct
Exactly.
whatever you see. So
Absolutely.
thank you very much, Dr. Asis. You can see lot of congratulations and appreciative comments in the chat box, and there are many, many more questions, but I don't think we have time to take them. I wish you could display your email ID in the chat box so that people whose questions have not been addressed, they can
Okay.
write to you directly. We have questions like, from Dr. Samarendra from Bhubaneswar. He wants to know about drooling. Then there is Radhika Mohan who wants to know activities for 7-year-old child with spastic diplegia, amblyopia, and behavioral issues. I'm sure it will take another hour for you to respond to these questions.
Yeah.
So please share your email ID in the chat box for everyone to note.
Okay.
And I hand over the screen to Asha Chitnis to conclude this. Asha, please.
Yeah, thank you, madam. Thank you, Dr. Meenakshi. Can I ask Madhvi to, yeah, thank you, Madhvi. I want, on behalf of our Mallikarjun sir, the president, Saktidas sir, our secretary, my board of directors, my executive body, I think so. I thank each and every one for participating, for always being present in our webinars. I thank Dr. Ashish for a lovely presentation and Dr. Meenakshi for a great moderation. Having said that, before I end and thank my webinar team, we want to let you know that next month, which is the month of October, we all need to remember that we celebrate October 3 as a Cerebral Palsy Day 2020. And why do we celebrate that? Because in the memory of the legend Dr. Pareen Mullah Feroz, who was a leading orthopedic surgeon. We have lots of activities planned over that month, which could be either the Saturday or Sunday. So 3rd October, we are really going to take look at Achievers. It's called Meri Kahani, Meri Zubani, which will be moderated by Dr. Shabnam Rangwala. On 10th October, we are having panel on guardianship and trust formation, which will be moderated by Jasmeet Arora. 17th October, we are really looking at getting somebody to speak from the International Alliance and also look at the challenges and sex education. We are looking at people who will be speaking on that. On 25th October, we have musculoskeletal health in cerebral palsy, preventive strategies that will be moderated by Dr. Ratna Maheshwari. And last but not the least, on 31st October, Adru sir will be looking at evening of music, dance, and fun by professionals and children. We all wish, and we will send you flyers, and we all wish that you all will be present. And I think so, on behalf of my webinar team, I thank each and every one. Thank you so much.
Thank you, Asha.
Thank you all. Thank you.